Hello, my name is Ravi Vij. I'm from My Cancer Haven. And today, in the Conversation with Cancer Expert series, we are hosting one of the preeminent hematologists of the country in India, Dr. Vikram Mathews, who is Senior Professor of Hematology and is currently Director of Christian Medical College, Vellore, one of the, again, premier, if not the premier, hematology institutes in the country. So we're really privileged to have him. Vikram, welcome.
Thank you. Thank you, Ravi. Thank you for having me.
So, Vikram, just to lay the ground, what is acute myeloid leukemia?
So acute myeloid leukemia is a type of a cancer. It's a blood cancer where in the blood there are different types of cells. There's on the white cells there are lymphocytes and there are myeloid cells. And this is an abnormal, uncontrolled proliferation of myeloid cells and usually the myeloid precursors. The cells don't differentiate normally. They have what we call an arrested differentiation and uncontrolled proliferation. There are many subtypes, which we won't go into detail. Globally, we think there's about 3 to 5 cases per 100,000 per year that are diagnosed with AML.
So, and then trying to put an Indian flavor to it, and how
Yeah,
is it in India in terms of
yeah,
epidemiology? Any difference?
right. Honestly, if you ask me my personal opinion, I don't see any reason why there should be difference. And if you refer to some of my publications that will point to where the issues are with the data, we don't have good registry data in the country. So whatever is reported would suggest, at least from tertiary and quaternary centers, that the incidence is slightly lower. But I think that's a referral bias. And again, because of that referral bias, patients coming onto tertiary centers, the median age tends to be around 40 years in our own series. And the Hematology Cancer Consortium, which is multiple centers in India reporting data, again gives a median age of 40 years. But this, in contrast to Western data, is data that is got from registries where you get a much older population. So there's two factors. One is our populations are younger in general, and the population pyramid is older in the West. So we do see younger patients, but again, as I said, there's a difference where the data is sourced from. Most of the data in India is sourced from tertiary centers, and the population data is much more robust in the West, where you see the median age being much higher. We've looked at the molecular patterns and the type of AML, and at least in a very large series from our center, we don't find any difference in the type of risk groups or different molecular subtypes of AML compared to what is reported in the West.
And how do patients typically present?
Yeah, so symptoms are usually a very acute illness, usually. It's either fever, just feeling tired or weak, and often, unfortunately, it's just picked up on a blood test for some very non-specific symptoms. And then you find these abnormal cells in circulation, and subsequently you do a bone marrow, and that confirms the diagnosis of AML. The problem in India is many of these early symptoms are ignored, or they go to various smaller hospitals and are treated non-specifically, empirically with antibiotics, etc. And as a result, in India, patients often present late with infections, which adds significant challenges to their subsequent treatment.
So, as far as the diagnostic workup goes, I know a lot of tests have to be done. So, how do you
Yeah.
approach it?
Yeah. So basically, when a patient comes in as suspected, we do the peripheral blood is often suggestive or very strongly suggestive, and a bone marrow is done to confirm it. Uh, there are certain tests that have to be done, which is the cytogenetics and molecular tests. And today in India, actually, next generation sequencing is widely accessible through various providers. These patients should not be treated in a small peripheral, small hospital. Ideally, they should be referred to a tertiary center close to where the patient is diagnosed. And so with these cytogenetics and molecular tests, especially for tests that classify patients into good risk or high risk, those tests need to be done and as early as possible. That has an impact on how we subsequently treat these patients.
So, I guess when you have to decide how to treat, you first risk stratify. Is that how you go about doing things?
That's right. That's right. So the molecular test may take a little time. We may at times start treatment, but once a result comes, that has impact on how we, after the initial treatment, which we call the induction, The subsequent treatment is basically consolidation or a transplant, and we decide who needs a transplant and who needs only chemotherapy, often based on these tests. So, for example, certain parameters like favorable cytogenetics like 821 or inversion 16, you may not want to go for a transplant after he achieves remission with the initial induction therapy. Same for NPM1. But for others like FLT3-ITD mutation, you may want to consider allogeneic stem cell transplantation in first remission.
So, as regards the treatment landscape goes, are you able to access all the drugs for these patients?
Yeah, so there's a shift in India. There's more and more patients being treated with less intensive therapies. The standard treatment for AML was a combination of an anthracycline drug for 3 days and cytosine for 7 days. We often use the acronym 7-3, which is a fairly intensive induction therapy. And at the Hematology Cancer Consortium, actually, we recently evaluated our data. Less than 20% of patients are actually getting conventional 7-3 plus induction. And even though the data is not there, most patients are now being treated on a hypomethylating agent plus venetoclax. Other drugs, midostaurin is available and venetoclax is available. Gilteritinib and ivosidenib have just been introduced, but are fairly expensive and difficult to access for most patients. Cost is a significant barrier for many of these targeted therapies for patients.
And what about supportive care?
Yeah, supportive care is really the key. Most places will not treat a patient in HEPA filtered rooms at this point in time. Where possible, that should be done. You also have to have a center, as I said, preferably these patients should be treated in a tertiary center with a good 24 access to laboratory and blood bank services. That's absolutely critical to take these patients to therapy, which is fairly intensive. Fair amount of cytopenia and complications can happen, and there should be 24/7 availability of support to take these patients through these treatments. Of course, psychosocial support, family support, social support is important. And the major challenge in India is, of course, financial barriers that make therapy with AML quite challenging for families.
So, and how are the outcomes?
The outcomes, I would say, in what I would call less than 55 years of age, fit patient with a conventional 7-3 induction, followed by consolidation with chemotherapy or transplant, you're looking in a favorable risk group at almost 60-65% long-term survival, our own very, very mature long-term follow-up data. And similarly, patients who have transplanted an allo transplant in CR1. Of course, the proportion of patients who receive this kind of standard therapy is still in India a small fraction, and a vast number of patients who really need these therapies are not able to access it, mainly because of the financial toxicity, late diagnosis, and challenges with allogeneic stem cell transplantation, access to allogeneic stem cell transplantation.
And what about the research environment in India? You mentioned some registries, and
Yeah.
obviously your institution is,
Yeah.
been generating a lot of data and publications and heme
Yeah.
malignancies. But where do you see the field going in India?
There's a good collaborative group called the Hematology Cancer Consortium, which has almost now 30 centers contributing data. Still, compared to the West, it's a relatively early or recent onset registry. But putting together collaborative data and capturing data on the types of treatment patients are getting for various hematological malignancies. Generic azacitidine and venetoclax is available. And a lot of patients, as I mentioned, have moved. And there is a debate on how right that is, even in young patients without adequate data. But the early treatment-related mortality with a conventional 7-3 or more intensive induction has made many physicians in India move rather preemptively, without waiting for the clinical trials into therapy with hypomethylating agents and venetoclax. And we are hoping that at Hematology Cancer Consortium, we can generate some data on the impact of these changes on whether this is actually translating to improved clinical outcomes, or is it just that more patients are given induction therapy and it's not actually translating to improvement in overall survival? That's some data that we have to work at.
So, what are your, recommendations as to how the field can advance and how outcomes can improve?
I think India, we need to do our own research. I think that's very important. And I feel that sometimes recommendations that are there in the West, whether it's intensification of therapy and all, may not really apply in India. We have significant challenges. Obviously, the financial toxicity and the management of complications of intensive therapy. We also have a significant problem with multi-drug resistance organisms. So cytopenia and morbidity translates much more into mortality in India than in the West, probably. And the supportive care systems are much more advanced in the West. We need to have better and earlier diagnosis for patients and molecular testing. We need to have financial resources and support both from the government and from NGOs to improve access for transplant for patients who need it, and also for some of the drugs, support from the government and from various NGOs would really be helpful in improving access to care.
So, to conclude, what are your key takeaways for the audience?
Yeah, I think the key takeaways are AML is a significant healthcare challenge to treat in India. We do have younger patients, but as I said, that may be because of a population pyramid situation and also tertiary, the data coming from tertiary centers. Financial challenges are the major hurdle. It's a very expensive disease to treat, and 85% of the patients are making out-of-pocket expenses predominantly for their treatment, which is a major, major barrier for accessing standard of care therapy. When we are doing newer therapies, we need to systematically evaluate protocols and regimens. Otherwise, there's a lot of heterogeneity in how people are treating AMLs. And at times, unfortunately, not necessarily doing what is best for the patient's chances of long-term survival. I think there's been a lot more coordination between academic centers, NGOs, and the government to try and improve access, standardization of care delivery, and multidisciplinary approach to improve outcomes.
Well, I wish to thank you very much for taking the time to educate the audience about AML. And obviously, you are one of the leading figures in AML in India, and your organization that you lead obviously is leading the way. And so I really wish to thank you and your organization for all you're doing.
Thanks, Ravi. Thank you so much.